So, very good evening to all of you. Welcome to the image based session. And this is going to be really very important, very interesting, and very high yield. So, welcome to the Ophthalmology High, Mulay. I think you all have been waiting for this, and I was getting enormous request because the paper time is there in the air, and there are certain images which you are getting very frequently. So this is specially designed. Today's session I have specially designed. Yeah. So obviously, this session will remain afterwards in the YouTube also. You can see it afterwards also. And today's session I have specially designed keeping the FMG examination in mind. Though it will be useful for all the PG aspirants also, right? So, we will be taking care of now. See what happens whenever we are discussing the images. Now, either we are looking at images or we are doing the questions related to the images. But today's session is something very different. I'm going to talk the images in terms of the theoretical aspect along with the questions that they have come up, or they can come in the upcoming examinations. Now, because we are having lot of questions in your examination based on the conjunctiva and cornea. If you look at the last 3 to 4 year papers, most of the images are either from the funders or very unique kind of images they are asking from conjunctiva and cornea. And repeatedly they are asking. So today I thought that I'll be focusing on conjunctiva and cornea, how to actually differentiate the different kind of ulcers, the different conditions, and as far as your theory is also concerned, a lot of questions from the degenerations also. So we'll be talking about that. So can anybody tell me about my audio video, and let's get started. Can we start? Anybody who can comment on my audio video? Alright. So first of all, if you look at this, we have the layers of the conjunctiva. So if you start with this conjunctiva, actually what do you mean by this conjunctiva? Alright, thank you Deva. Thank you. Yes, and I think there are two important announcements also that I have to make. It's a very precious moment for all of us, and I think for you people also, because now 3.0 videos are live. So go and take the maximum benefit of it. And your NEET PG mock is going to expire in 13 hours. So please go and attempt it. It's a very good paper that we have made, and questions are made keeping the upcoming paper in mind. NEET PG 2022, how that paper will be coming, not keeping that paper that have already gone. Okay, so the papers that you are likely to get according to the latest pattern, what NBE has decided. So we have kept the mock paper according to that. So please, you have to do this. Alright. So let's get started with the conjunctiva. See, conjunctiva, when I use the word conjunctiva, what does this mean? Conjunctiva means to conjoin, right? So this means to conjoin. So basically, if you have the two eyelids and you have the eyeball in the center, so you require a membrane that can join the two things. That is actually the conjunctiva. So this conjunctiva is nothing but a translucent membrane. So it's a translucent membrane. Translucent is something which is in between the transparent and opaque. Like, transparent is your cornea, transparent is your lens, and the opaque is the sclera. So something in between through which the details are partially visible, that is actually the translucent. So that kind of a thing is conjunctiva, which is joining the eyeball to the eyelids. Now when I talk about the parts of conjunctiva, there are 3 parts of conjunctiva. See this. One is your palpebral conjunctiva. Now can you see here, we have got the greenish area. So this green is lying beneath the eyelids. So that conjunctiva which is lying beneath the eyelids, suppose these are the eyelids. So when you evert these eyelids, that portion is called as your palpebral conjunctiva. Then second is your bulbar conjunctiva. See, this yellow one is your bulbar conjunctiva. So if you see here, the one which is present beneath this eyelids is the palpebral conjunctiva, and this one which you can see from the front, this white one, is your bulbar conjunctiva. So that is the difference between the palpebral conjunctiva and the bulbar conjunctiva, and the one which is joining the two is your conjunctival fornix. Now once you know what is conjunctiva and the different parts, then we will be studying the structure. Now before that, what is happening? We have got 3 parts of palpebral conjunctiva. Now these things always cause a lot of confusion. When I talk about the palpebral conjunctiva, that is one beneath the eyelid. So when you evert the eyelid, there is a plate in this eyelid. Okay, this plate is called as the tarsal plate. This plate is called as a tarsal plate. So the conjunctiva which is lying over this tarsal plate, that will be your tarsal conjunctiva. Okay, the one which is lying at the margins, this will be called as the marginal conjunctiva, and the one which is going backward will be your orbital conjunctiva. So basically we have got the 3 types of conjunctiva. Right? So we have got the 3 parts of conjunctiva. We have palpebral conjunctiva, we have bulbar conjunctiva, and we have conjunctival fornix. And when you evert this palpebral conjunctiva, this can further be divided into 3 parts. So I hope now the structure is very clear. Now if you see the parts of the conjunctiva, so we will go back to this image. See, there are 3 parts of conjunctiva, one, or we can say the layers of conjunctiva. So if you talk about the layers of conjunctiva, first is the epithelium. Now the first important question is, what is the kind of epithelium we have? It is the non-keratinized stratified squamous epithelium. Non-keratinized stratified squamous epithelium. Now what is the significance? See, this is your non-keratinized type. Now this is important because we require lubrication not only in the conjunctiva but also in the cornea. So what do we have? We have non-keratinized epithelium. Now why it is not keratinized? Because we have got the goblet cells. Another important question, because we have the goblet cells. Where do we have these goblet cells? We are present with the goblet cells all parts of the epithelium, and it is actually helping in the mucin secretion. It is actually helping mucin secretion, the important question number 2. Now that means if something goes wrong with these goblet cells, there will be no mucin secretion. So we have no mucin secretion in the conjunctiva as well as cornea. Therefore, there will be keratinization. Another important thing is, therefore, there will be keratinization of the epithelium, or we can say there is a metaplasia. Metaplasia means change of epithelium. So if I am having change of epithelium from the non-keratinized to the keratinized, this is also called as hyperkeratosis. This is also called as the hyperkeratosis. So this hyperkeratosis of the epithelium actually occurs in the vitamin A deficiency. So there are a lot of questions that can actually come here. Where first is the type of epithelium, then there is a change of epithelium, that is it is changing from non-keratinized to the keratinized. This is called as hyperkeratosis. Where does it take place? In the vitamin A deficiency. Why? Whenever we have the problem with the goblet cells, what is the action of goblet cells? Where do we have the goblet cells? And whenever I have a problem or I have the vitamin A deficiency, that is why we will have the conjunctival as well as the corneal xerosis. We can have conjunctival xerosis as well as corneal xerosis. Xerosis means drying. Is this clear, guys? Up till now, any question? Please keep on commenting. Yeah. So is it very clear to everyone? Right? Now the second layer. The second layer is the adenoid layer. The second layer is the adenoid layer. Now what is the function of this adenoid layer? Whenever I am talking about the adenoid layer of the conjunctiva, this actually consists of the follicles. It consists of the follicles, and follicles means you will have the lymphoid aggregations. We will have the lymphoid aggregations. This is again a third question that could be asked. Whenever we have follicles, we have lymphoids, we have got the follicular kind of conjunctivitis. So whether it is any kind of follicular conjunctivitis, it is always present in the adenoid layer, while the third layer is the fibrous layer. The third layer is the fibrous layer. Now when this adenoid layer and the fibrous layer are combined, then total is called as the substantia. Then this is called as the substantia propria. Then this is called as substantia propria, and it is this substantia propria where actually we get the degenerations. And mind you, a very important topic for your examination. I think no examination is completed in the FMG without asking about this conjunctival degeneration. So sometimes they ask you about 3 questions also from the conjunctival degenerations. So the conjunctiva, the parts of conjunctiva, the different layers of conjunctiva and their significance is very clear. Now after covering this, we will be, thank you so much for responding, Terry. Okay. Now we talk about conjunctivitis, and whenever we talk about conjunctivitis, it is this kind of picture that comes to our mind. See, when I talk about the conjunctivitis, actually we can have 2 kind of conjunctivitis, right? Let us talk very broadly. So we can have 2 things. Either I can have infectious conjunctivitis or I can have non-infectious conjunctivitis. Okay, either we can have infectious or we can have non-infectious. Now infectious is always more common. So in a developing country like India, we have got more of infectious conjunctivitis. And amongst the infection, which is most common? Can you tell me, anybody who is there? Can you guys tell me which infection will be more common in the conjunctivitis? Good evening everyone. Good evening Sahil. And Dr. DS, I think you don't have to worry. You have examinations and you are going to rock. And if we can help you in any way, please let us know for your examinations. Keep on following the clinical scenarios that we are doing every week, because university examinations mein viva and all, you require the clinical scenarios. So keep on following that. Anybody who can tell me what is the most common cause of conjunctivitis? Infectious one. Infectious one is most common. Now what is the most common infection? Most common infection will be the bacterial. So actually it is the bacterial. Another important question. See, these are the little questions that they can ask you. And in the bacteria, which is most common? So actually it is the bacterial conjunctivitis which is most common in the infections, and amongst the bacteria it is actually the Staph aureus which is most common. So in the final you can say that it is a Staph aureus kind of infectious conjunctivitis which is most common. Infectious most common, infection में bacterial most common. Bacteria का hero is actually the Staph aureus. So it is actually the Staph aureus which is most common. Now when I talk about bacterial conjunctivitis, what is the most common type? The most common type of bacterial is the mucopurulent. So there are so many most commons that you have to remember. Now when you talk about muco and purulent, muco means sticky. We have the sticky and purulent is the pus. So we have the acute mucopurulent conjunctivitis, that is most common. We have sticky discharge, we have got pus, we will have sticking of eyelashes, matting of eyelashes. Patient will say, I'm not able to open the eyes in the morning. There is yellowish discharge. Can you see typical kind of yellowish discharge you are able to see? So all these are very, very common. Can you tell me an important DD that you are going to get in acute mucopurulent conjunctivitis, guys? Acute mucopurulent conjunctivitis is a very, very important DD of the colored halos. Another important question when I talk about the colored halos. When I talk about the colored halos, it is a very, very important DD. Now, who will tell me the DD of colored halos? I have been telling you this for so many times. What is the DD of the colored halos? Number 1, we have a cataract. Number 1 is a cataract. Number 2 is a glaucoma. Which glaucoma? Acute congestive glaucoma. And number 3 is this one that we were talking about, acute mucopurulent conjunctivitis. So whenever you are getting a OPD case of conjunctivitis, it is these things that you have to look. You can ask the patient with the history of colored halos. You can ask the patient about was he able to open the eyes, yellowish discharge, right? We can have some kind of discomfort. Also, stye is not a cause of the colored halos, guys. Okay, stye is not the cause. We have got the cataract, we have acute congestive glaucoma, and we have acute mucopurulent conjunctivitis. Now, second important thing, what is a test that we can do to differentiate between the colored halos of this cataract and the acute congestive glaucoma? If I want to differentiate whether the colored halos are due to cataract or acute congestive glaucoma, then we do the stenopic slit test. The full name is the Finchem's. We have the Finchem's stenopic slit test. Finchem's stenopic slit test. So another important thing is the Finchem's stenopic slit test. Glaucoma, I think Sahil, the better answer is the acute congestive glaucoma, okay, because glaucoma can be open angle also. So this is your second one. Now coming to the other one. Now after after the mucopurulent, we can also have the purulent conjunctivitis. The purulent conjunctivitis. Purulent conjunctivitis means only pus. So when you are having only pus, this is actually caused by the gonococcus. This is caused by the gonococcus. Now, whenever we are talking about the gonococcus, you know that gonococcus is a very, very virulent bacteria. So, all the things related to gonorrhea you have to keep in mind. You know, this is the way how you have to learn the things in the integrated manner. You know about Neisseria gonorrhoeae. It's a virulent bacteria. Then it can cause the systemic manifestations. We can have urethritis. We can have arthritis. And another important thing is that it can penetrate the intact cornea also. Now, most of the times what happens, how bacteria causes the corneal ulcer? Bacteria is not invading the intact corneal epithelium, right? It is doing what? It is actually first, if there is a epithelial erosion, then secondarily it can infect this corneal erosion. But some bacteria are smart enough and they can invade this intercorneal epithelium, and Neisseria gonorrhoeae is one of them. So if I am having this conjunctivitis by the gonococcus, then we can have the chances of corneal involvement also. Now, because I am having the chances of the corneal involvement, another important question, which drug you should give because of the corneal involvement? This is one question. And second, because it can cause the systemic features also. Systemic features. Because it can cause the systemic features also, therefore what you can do. So there are two important things. First question is, because we can have the corneal involvement, therefore the drug that you have to give is the atropine. A very, very important question. Which drug should be given for the corneal involvement? Second thing, because it is having the systemic features also, therefore we give the systemic antibiotics. The systemic antibiotics. So most of the times we are giving just the topical antibiotics, but in cases of the gonorrheal infection we can give the systemic antibiotics also. We have to give the systemic antibiotics because here we are having the systemic infection also, while other places we are just giving the topical antibiotics. Okay, all right. Now see this one. A very, very important conjunctivitis that you can see here. Can you see this here membrane kind of a thing? We are having this one. So what is this? This is actually a membrane, and therefore this is a kind of the membranous conjunctivitis. Now whenever we have the membranous conjunctivitis, the membrane is present in the conjunctiva. Which conjunctiva? It is present in the palpebral. It is present in the palpebral conjunctiva. The first important thing. Now, just by looking, you cannot say whether, it's a true membranous conjunctivitis or it's a false membranous conjunctivitis. So this membrane which is present in the palpebral conjunctiva, it can be densely adherent or it can be loosely adherent. So if it is densely adherent, there will be bleeding on peeling it off. A very, very important thing. So if I have bleeding present, then this is called as the true membranous conjunctivitis, and obviously if the bleeding is absent, then it is a pseudo-membranous. So most of the times the question that you get in cases of membranous conjunctivitis is how to find out whether it's a true membranous conjunctivitis or it's a false membranous. True membranous membrane is densely adherent on the palpebral conjunctiva, while in the pseudo membranous it is just loosely adherent, so there will be no bleeding off. Okay? Now another important thing, a very, very unique kind of conjunctivitis which is found in bacteria, where we have the no polymorphonuclear response. Another important question, which is the bacteria which is not causing polymorphonuclear response, and therefore there is no discharge. No polymorphonuclear response is there, therefore there is no discharge is there, and you are getting something like this. We are getting the eczema. So this is caused by the Moraxella exenfeld. Now can you tell me what is this? It is caused by the Moraxella exenfeld. So what kind of conjunctivitis is this? Very frequently asked. Moraxella exenfeld. Yes, very good. Yes, so all of you are correct. Moraxella exenfeld, this is causing the angular conjunctivitis. This is causing the angular conjunctivitis. So this angular conjunctivitis which is caused by the Moraxella exenfeld, this actually releases a enzyme. What is that enzyme? It is called as the proteolytic. Is this font size okay, guys? Are you able to read? Proteolytic enzyme. So this proteolytic enzyme is actually accumulated in the tear film. It is accumulated in the tear film, and from that tear film it is causing the eczema, the maceration, the drying. Now, who will tell me the treatment of choice for this? Come on. What is the treatment of choice for the angular conjunctivitis which is caused by Moraxella Axenfeld? So, Gamma knife, Raja, Prajapati, and yeah. So, everybody of you are correct. Now, you have to tell me the treatment of choice, because maximum times when they're asking the question on Moraxella Axenfeld or the angular conjunctivitis, they are asking you the treatment. So, anybody who knows what is the treatment? Alright, I'll try to give you the PDF, but the thing is that we keep on collecting the PDFs and we never read it. This is the experience, but the things that you are actually listening or you are hearing in the classes or in the sessions, you are reading that only, okay? But if you want, I'll share the PDF, that is not a problem. Okay, now see this, a fiery appearance, है ना? Fiery red eye. No, topical antibiotics are not the treatment of choice. So always remember, guys, for the angular conjunctivitis. For the angular conjunctivitis, the treatment of choice is zinc. Always remember, very, very important question. Yes, video will be available later, not a problem. Okay? Okay, now see this. So, whenever I talk about the viral conjunctivitis, okay? When I talk about the viral conjunctivitis, the first important virus that is in our mind is the adenovirus. It is actually the adenovirus. Okay? So, like bacteria में जो hero है, the hero of bacteria is the Staph aureus. Virus का hero कौन है? It is the adenovirus. Now, what kind of conjunctivitis can be caused by the viruses? A very, very important is a follicular conjunctivitis. Okay? Now, when I talk about the follicular conjunctivitis, always remember that there are two forms of the follicular conjunctivitis. One is the epidemic. Matlab, when you have lot of, eye flus that you say, they are spreading in the societies, in the hostels and the colonies, everywhere. That is your eye flu or the epidemics. That is caused by the adenovirus, which is species. We have 8, we have 19 and we have got 37. So 8, 19 and 37. While the one which is causing the typical viral fevers. What do we have in typical viral fevers? Pharyngoconjunctival fever. Pharyngo means pharyngitis, sore throat. Conjunctivo is a conjunctivitis. You have watering and you have fever. That is your 3, 4 and 7. So we have got 3, 19, 37, 8, 19, 37 and then 3, 4 and 7. While the khatarnak one is your hemorrhagic conjunctivitis, this one. And this has been actually asked so many times in your DNB examinations also. This is your acute hemorrhagic conjunctivitis. Now always remember, when I talk about follicular conjunctivitis, when I talk about hemorrhagic conjunctivitis, then it is always the virus. Okay, there is only one bacteria which is causing the hemorrhages. Only one bacteria which is causing the hemorrhages. Okay, note it down. This is your pneumococcus. This is your pneumococcus. There is only one bacteria that is causing the hemorrhages, that too the pedicle hemorrhages, that is the pneumococcus. Otherwise, hemorrhages means the virus. Now, when I talk about acute hemorrhagic conjunctivitis, again, lot of questions from this. What is causing this acute hemorrhagic conjunctivitis? It is caused by the picoRNA virus family. picoRNA virus family, especially it is caused by the enterovirus type 70. Then we can have the adenovirus, and then we also have the Cox virus. Always remember, we have got these three. Okay, like if you remember, we have got the pox now. So P for picoRNA virus, then we have got the A for adenovirus, and then X is the Cox virus. So you can remember it like this. And the most important member of your picoRNA virus family is the enterovirus type 70. It is actually the enterovirus type 70. Now one more thing which is important here. Can you see It resembles the acute red eye. What is acute red eye, guys? Acute red eye means where you have, fiery red appearance, you have a lot of congestion. What kind of congestion do we have in the acute red eye? We will have circumcorneal congestion. What kind of congestion we will have is the circumcorneal congestion, right? Circumcorneal congestion, what do you mean? See, when I talk about the eye, it is something like this, and you are having the inflammation all around this cornea, like this. When we are having the inflammation all around the cornea, and it is going towards the fornices. The fornices are clear, okay? It is towards the fornix, but it is near the limbus. This is actually called as your circumcorneal congestion. So where do you get it? You get it here in the acute anterior uveitis. This is your acute anterior uveitis. Very, very important is your acute anterior uveitis. Then the another one is your acute congestive glaucoma, right? Then a very, very important thing is your chemical burns. The injury, it can be acid burn or it can be a alkali burn, okay? And then we can have the acute bacterial keratitis. Very, very important, DD. I must say this is very, very important, right? This is actually, a lower one which you can add on in giving the examples for your acute red eye, because genuinely when I talk about the acute red eye, your important causes will be acute anterior uveitis, we will have acute congestive glaucomas, we will have chemical injuries, lot of inflammation, lot of necrosis, you can have the bacterial keratitis. So this is not the exact cause, but that can resemble the acute red eye. So this is your hemorrhagic conjunctivitis, okay? Then all-time favorite of all the examiners. All-time favorite of all the examiners is what? Is the trachoma. And I'm telling you one thing. It is 2022, means you are going to get a question. Trachoma is covered in micro, PSM, infectious diseases, ophthalmology. So I do not know what aspect of trachoma they are going to ask, but I know trachoma will be asked, right? So trachoma is also, it is also a part of your Vision 2020 program. We have got WHO control control program for the trachoma also. Now, why trachoma is so important? Because trachoma is actually, if I talk about the trachoma, it is the most common infection. Most common infection in India which is causing the blindness. So we are covering the images along with the questions that have been asked and that can be asked. So most common infection that is causing the blindness in India is trachoma. Its other cause name is Egyptian. Its other name is Egyptian ophthalmia. Its other name is the Egyptian ophthalmia, and the important thing is that it is causing a chronic keratoconjunctivitis. Like if I talk about the bacterial, if I talk about the virus, they were your acute keratitis. But when we talk about the trachoma, it is the chronic keratoconjunctivitis. Kerato means cornea is involved and conjunctivitis means the conjunctiva is involved. So basically it is a condition where both cornea as well as conjunctiva is involved. So 3 C's. This is your C to the power 3. So always remember CT होता है ना, CT scan, ठीक है ना? तो T for trachoma and C3. C for we have got the chronic, C for cornea, C for conjunctiva also, and then you have C for one more thing, the chlamydia, है ना? We have C for chlamydia, एंड T फॉर ट्रैकोमेटिस, तो ये 2 हो जाएगा क्लेमाइडिया ट्रैकोमेटिस, है ना. So we have got the chlamydia trachomatis CT, which corresponds to CT. T for your trachoma, and then you have got C for cornea, C for conjunctiva, and C for chronic. Another important thing is that it is showing a mixed response. Mixed का मतलब क्या है? It is showing me follicles also, and it is showing me papillary hyperplasia. Now whenever we have conjunctivitis, it is always, something like this, that either we are having, it is usually affecting the children. Yes, it is usually affecting the children. What happens, see, whenever we have any kind of conjunctivitis, either you will see follicles or you will have papillary hyperplasia, but trachoma is one place where you are seeing both. So what kind of follicles do we have? Beautiful, है ना? These are your sago grain follicles that you are getting. Sago grains, sabudana. So when you are boiling the sago grains, sabudana khichdi dekhi hai na, sabudana. So you are getting these pearly white color. You are seeing this pearly white color. So these pearly white, follicles that you are getting small, these are called as sago grain follicles. Now sometimes, you have a confusion that whether or not these are sago grain follicles. Then what we can do the microscopy. So when you do the microscopy, you will get 2 things. One is your Leber cells, micro part hai ye. You are getting the Leber cells, and you are seeing the signs of the necrosis. So you are seeing the Leber cells and the signs of necrosis, and you are sure that this is a case of trachoma only. While the second thing is the papillary hyperplasia. Now most of the students have some confusion. What is papillary hyperplasia? First of all, try to understand what is papillae. So when you invert the eyelid, you have the blood vessels there. So these blood vessels, these blood vessels are called as papillae. So when we have the hyperplasia of this papillae, they will become something like this, radish, they are flat topped, they are giving a velvet like appearance, a beautiful. Yeah, this is the weakness of the medicos. The patient is diseased and we say beautiful. So in terms of signs only, okay na? So whenever we have got the papillary hyperplasia, it's a beautiful velvet like appearance that we are getting. So we are having the sago grain follicles along with the papillary hyperplasia. Now come to pathology. Micro part हमने discuss किया. Now ophtha part हमने discuss किया. Now come to pathology. Whenever we have inflammation, we will have the scarring, we will have the fibrosis. So fibrosis will come in the form of the Art's line. You must have heard about the Art's triangle also. Art's triangle is found in the acute anterior uveitis, while this is your Art's line. Art's line mein we have the scarring which is found in the sulcus subtarsalis. So suppose here we have a sulcus, that is tarsal plate. So beneath the tarsal plate, I showed you the tarsal plate na. Suppose this is your upper eyelid and this is the tarsal plate. So beneath this you have a small sulcus where you will have the scarring, something like this. So this line of scarring over the sulcus subtarsalis is actually called as a Art's line. This is again a very important question. Art's line is a feature of. Now whenever we have follicles, we have got the papillary hyperplasia, we have Art's line. So we have something which is called as the concretions. What is these concretions? Can you see these collections here? These are the collections of the dead epithelial cells. Dead epithelial cells, plus we will have the debris. So whenever we have the collections of the dead epithelial cells along with the debris, it is called as concretions. Now suppose this was the eyelid and you are having a lot of concretions, and I close this eyelid. So they will actually, rub the cornea. So they have a property of causing the corneal ulcer. And why I am worried about corneal ulcer? Because corneal ulcer is the only complication. It is the only complication of the trachoma. So rest of the things, they are the sequelae. That is the difference. Rest of the things are the sequelae, while corneal ulcer is the only complication of the trachoma. Okay, so these are your conjunctival signs. Now we come to the corneal signs. Very, very important. Now, whenever we have got the follicles in the trachoma, similar follicles I will have in the cornea also. So I will have the Herbert follicles. Again, a very important question also, Herbert follicles and the Herbert pits. Herbert follicles and the Herbert pits are actually found in cases of the trachoma. They are in cornea. Now you will say, are they different? No, they are not different. They are same sago grain follicles which are having the, on microscopy we have the Leber cells. We have got the signs of necrosis. But, they are placed at a different position. Instead of conjunctiva, they are present on the cornea. Therefore, they have got a different name, and here they are called as the Herbert follicles and Herbert pits. So if you do the microscopy, you will have same sago grain follicles, you will have the same Leber cells, you will have same signs of necrosis, and gross maybe they will be looking like same sago grain follicles. Now, why do I have pits then? Pits were not present in conjunctiva, but here I have pits. Pits, you can say these are the pits. These pits are the depressions. So these pits are the depressions at the side of the follicles. These are the pits at the site of the follicle. So why we are actually getting these depressions? Because cornea is avascular. See, conjunctiva was getting follicles, but it was vascular, so we were having the healing. But cornea is avascular, so we have no healing, and we are getting these pits or the depression. So Herbert follicles and Herbert pits are the two very, very important signs that you are getting in cases of the trachoma. Alright, now another important thing that you get in cases of the trachoma is the pannus. Now what is this pannus? Pannus is actually the name for corneal ulcer itself. I told you corneal ulcer is the only complication of trachoma. See what happens, conjunctiva is vascular, cornea is avascular. Now when I have chronic keratoconjunctivitis, okay? So if I have inflammation both in the cornea as well as in the conjunctiva, the vessels from the conjunctiva will grow over the cornea. Can you see here these vessels from the conjunctiva? They are actually growing over the cornea. So whenever these vessels are growing over the cornea, along with the RBCs, along with the blood vessels, they are also bringing the lymphocytic infiltration of what do you else require for ulceration. So if I have vascularization also, I have lymphocytic infiltration also, they will be going deeper and deeper, and they will be causing corneal ulcer. So a very, very important thing, concretions was there, that was causing corneal ulcer. Pannus is also causing corneal ulcer, and finally we can have the opacity. Now another important thing is your Fisto classification. If I talk about the WHO staging, if I talk about the WHO staging of the trachoma, the WHO staging is called as the Fisto classification. Okay. Now let us try to understand what is this Fisto. First is your F. F means follicular. So we have already talked about it, that we will have the follicles also, and we will have papillary hyperplasia also. And what are the kind of follicles? We were having the sago grain follicles. Sago grain follicles. So we were having the follicles also and the papillary hyperplasia. So F is the follicles, and what kind of follicles? The sago grain follicles we will have. Okay, then we have got I. I for the intense inflammation. We'll write here, it is the intense inflammation. So this intense inflammation, where you are getting this intense inflammation, is actually the papillary hyperplasia. papillary hyperplasia. So you have already seen that we are having the sago grain follicles also, we are having the papillary hyperplasia also, and then S is pretty simple. As for scarring, in that we were having the Arts line. So Arts line was the scarring in the sulcus subtarsalis, and then we will have T. T is for trichiasis. Now what is trichiasis? Look at this picture. I'll highlight it. Can you see these eyelashes here? Okay? So these eyelashes are actually rubbing the cornea. See what happens in cases of trachoma, we can have inward turning of the eyelid margin. We never have outward turning here. We will have the inward turning of the lid margin, due to which the eyelashes can be rubbing the cornea even if one eyelash rubs the cornea. Even if one eyelash rubs the cornea, then this is sufficient to call it as trichiasis, and trichiasis can again cause the corneal ulcer, which is the complication of the trachoma. And finally we have opacity. Opacity is there, and due to the opacity it can cause blindness. So what is the reason why it is considered to be an infectious cause which is responsible for the blindness? It is actually this corneal opacity only which is responsible for the diminution of vision. Very, very important. Another important aspect is the safe strategy. Recently there was a question on this in the 2021 also, where they had changed this E and they had asked which of the following is not correct. So this safe strategy, which is amongst the rural part, the PSM part of the trachoma, again very, very important, we are following is the safe strategy. Now see, these are the things you cannot change according to your language. You have to abide with the fixed words. So as for the surgery basically we are doing for the lid deformities, and the most common is your trichiasis. We have already discussed what is trichiasis. Then A for antibiotics. Now when I talk about the antibiotics, we can use erythromycin, we can use the tetracycline. So tetracycline or these are used in the form of eye ointment, but nowadays a single drug regimen is most commonly used. There we are using the azithromycin, 1 gram oral stat you can give. So that is your azithromycin. Then F for facial cleanliness, and last is your environmental hygiene. So this was given wrong and they had asked which of the following is the wrong one. So this is covering whole of the trachoma. I must say a very, very important thing, a very, very important thing. Now see this baby, baby is there. So this baby trachoma, yes, trachoma safe strategy, yes Jyotsna. Now this is your Ophthalmia neonatorum. So Ophthalmia neonatorum, here we are having the conjunctivitis. Conjunctivitis. So if I am having this conjunctivitis, neonatorum means it is in the neonate. If you are having the conjunctivitis in a neonate means less than 28 days. If I am having the conjunctivitis in a neonate less than 28 days, then this is actually called as conjunctivitis. And how will you actually suspect? Due to any discharge from the eyes of the baby less than 28 days should arouse the suspicion of the Ophthalmia neonatorum, because tears are not formed till then. What is the time of tear formation? If you talk about the tears, it is between 4 to 6 weeks. So before that, any kind of discharge that is taking place is actually the Ophthalmia neonatorum. Now there are two questions that was asked in 2018. One was the most common and one was your most severe. Okay, so always remember the two things. The most common cause of this neonatal conjunctivitis, that is the one that we have just discussed. It is the chlamydia trachomatis. It is the chlamydia trachomatis, and this most common, which is causing at the time of birth, this is your neonatal inclusion. Neonatal inclusion conjunctivitis. This is your neonatal inclusion conjunctivitis, while the most severe is actually the gonococcal. The most severe is actually the gonococcal. So whenever they are asking you what is the most common cause of neonatal conjunctivitis, what is the most severe cause of neonatal conjunctivitis, always remember these two things. Again, very very important questions. Okay? Alright. Now moving forward, and the iconic for your exam is the allergic conjunctivitis. I think no FMG examination is complete without certain things. Okay, तो clear है, good है. So I think this picture is mandatory and you are going to get this picture in 2022 also. So, out of the infectious and the non-infectious, it was infectious that is most common. But if I talk about the non-infectious, in the non-infectious, it is the allergic conjunctivitis that was most common. And in the allergic, it is the VKC that is most common. VKC means we have the vernal keratoconjunctivitis. It is the vernal keratoconjunctivitis that is most common. So actually the word vernal means spring. So because it was a misnomer that it was common in the spring season, that is why it was named as vernal keratoconjunctivitis, and they also call it as a spring catarrh. They also call it as spring catarrh. So this is very very common in the young males. This is very very common in the young males, and the typical thing that you are getting is your itching. Always remember you are going to get the itching. Now one more dictum, whenever you are having itching in the question, always go for allergy. So itching means allergy. So this person is going to have intense itching, and a typical kind of discharge that you are going to get is the ropey discharge. So when you are having a clinical scenario, you are having a young male, you are having bilateral itching, you will have ropey discharge, you have the type 1 hypersensitivity reaction to the exogenous allergens. We have the exogenous allergy. So if I have type 1 hypersensitivity reaction to the exogenous allergens, we have a ropey discharge. Just think of VKC and you get typical, polygonal raised areas. It could be hexagonal, it could be pentagonal, something like this is there. So this polygonal raised areas, which can be pentagonal, which can be hexagonal, this is typically called as what? This is very very typical, called as the cobblestone papillae or the cobblestone appearance. This is cobblestone papillae or the cobblestone appearance, and along with this, a very very important thing is the Horner-Trenta spots. We will have the Horner. These are also called as just the Trenta spots, or they can be called as the Horner-Trenta spots, and basically they consist of the eosinophils. Another important question, that they consist of the eosinophils. You can see we have got these grayish white spots which are near the limbus. Can you see how they are different from the Herbert pits? See, Herbert pits were found in the trachoma, and pebblestone appearance, it's a cobblestone appearance. Here it says, I think it was a typo error. How these Horner-Trenta spots are different from your Herbert pits? Herbert pits were found, they were below the limbus, they were darkish in color, blackish in color, they were in trachoma, while here you are having grayish white and you are having above the limbus, and these are found in the spring catarrh or the vernal keratoconjunctivitis. If you look at the cornea, so in the cornea also you will have ulcers. These are called as the shield ulcers. In the cornea we will have the shield ulcers. So young typical male, bilateral, interstitial, type 1 hypersensitivity reaction to the exogenous allergy. We have got the itching is there, ropey discharge is there, cobblestone papillae is there, we have Horner Twenta spots, we have shield ulcers, and you are clear that this is a case of VKC. So what will be the treatment of choice? It is the olopatadine. It is the olopatadine which is the treatment of choice. It is a combined antihistaminic plus the mast cell stabilizer. So a very good one. Yes, if it is not working, then we will the second line pe we can go for the steroids. Why not the first line of drugs for the steroids? Because steroids can cause GTCS. Steroids can cause GTCS. Topical steroids can cause glaucoma, and systemic steroids can cause cataract. So always remember the mnemonic GTCS, and that is the reason. I do not want that I treat the allergy, but I am causing the cataract and glaucoma in a young male. So that is why I am not giving the steroids as the first choice. Okay. Now, on the other hand, we have got another allergic conjunctivitis. This another one is called as your filictinular. This is filictinular keratoconjunctivitis. So you can see this is formed from the word filictin, and this filictin means a nodule. So we have a nodular keratoconjunctivitis. It is a nodular keratoconjunctivitis. We have a nodule, and you can see a pinkish nodule near the limbus is there, which can slowly and gradually burst over the cornea, and we can have typical ulcers. Now the main challenge is how to differentiate between the VKC and the filictinular keratoconjunctivitis. So there are certain things that you should always see, like VKC is more common in males while filictinular is more common in females. This was a diffuse allergy, while this is a nodular keratoconjunctivitis. This is your type 1 hypersensitivity reaction, while this is type 4 hypersensitivity reaction. Then this is your exogenous allergy, while this is the endogenous allergy. So these are the common things, and obviously you can look at the age of the patient, you can see the signs. We have the cobblestone papillae, we have Horner Twenta spots, we have the shield ulcers, we have ropey discharge. So these are the different things again which will help you to differentiate whether it is a vernal keratoconjunctivitis or it is a filictinular. Alright. Now we finally come to the degenerations. And this is again, the showstopper, I can say, because conjunctiva question is definitely coming from degenerations. So conjunctival degenerations, that they are found in the substantia propria. Filictin and nodular scleritis. See, scleritis is a very, very painful condition. Plus, scleritis is most commonly associated with the connective tissue disorders. So, if you have scleritis, they will give you some clue association with connective tissue disorder. They will give you that there is a lot of pain. They will tell you whether there is a blenching with the phenylephrine or not. On the other hand, if you have filictin, then it's an allergic conjunctivitis. So in that case, they will give you some clue towards the allergy, like itching, some clue towards the staph proteins, because mostly it is the staph protein allergy or the tubercular protein allergy. So obviously they will give you some clue also. So it is not that at your level they will not expect you to just find out from the images. Then obviously entire images of the ophthalmology will not be is not a possibility in just 1 hour, because I am discussing each and every point regarding that image. So we will be doing in a series of sessions. So today we will be completing the conjunctiva, and the next session I will be taking the cornea, right? So in the degenerations, we have got the two. One is your pingicula. This is your pingicula, and another is pterygium. Now try to understand. See, pingicula word is formed from the word pinguis. And pinguis means lipid, lipid means yellow. So basically here we have just the yellowish discoloration, which is stationary, which is just a degenerative condition. What kind of degeneration we have? We have the elastotic kind of degeneration is there. And even if it is growing away from the cornea, so it's not causing any symptoms, and therefore no treatment is required. Other than sometimes people complain of cosmesis, we do not have any problem. But when I talk about pterygium, it's a dangerous thing. Now see one more picture of pterygium. This was asked in 2019 also. So pterygium word is actually formed from the word pterygos, and pterygos means wings. So this is a wing shaped fold of the conjunctiva which is coming over the cornea. It is pressing the cornea. So basically it is causing the astigmatism, right? So whenever we have the pterygium, it can come over the limbus, it can go even anteriorly up to the pupil, it can obstruct the pupil. So if it is going anteriorly from then here, so obviously we can have obstruction of the pupillary axis. But every pterygium will not obstruct the pupillary axis, while every pterygium will cause astigmatism. That is why it is actually astigmatism that is the most common cause of the diminution of vision. Alright, now see this. We have another important thing in the pterygium, and that is called as the Stalker's line. Again, a very very important PYQ for your FMG exam. So we have the deposition of iron anterior to the advancing head of the pterygium like this. This is called as the Stalker's line. This is nothing but the iron deposition. So if I am having the iron deposition anterior to the advancing head of the pterygium, then this is called as the Stalker's line. Like we have a KF ring in the Wilson's disease, here we have the Stalker's line. So what can I do? I can do the surgical excision. The third important thing is the treatment of choice. I can do the surgical excision, yes, but the problem is the recurrence. So because there are many chances of recurrence, 30 to 80% cases will reoccur. So a very very important thing again for FMGs is how to reduce this recurrence. You can reduce this recurrence by the mitomycin C. We can give the thiotepa we can give. Then number 3 is your conjunctival autografting. We can do the conjunctival autografting. We can do the beta radiations we can emit. And then number 5 is the amniotic membrane grafting. Amniotic membrane grafting also we can do. So these are the important things with respect to the pterygium. And 1 year there was a paper of FMG examination where there were 3 questions consecutively in the same set from pterygium. They asked the Stalker's line, they asked the treatment of choice, they also asked the drugs which are used for reducing the recurrence. So this is the A to Z image based session of conjunctiva. I have told you everything that is important, each and everything which is important, all the PYQs related to conjunctiva, all the images we have discussed, whatever is important, and whatever can be asked from conjunctiva. So next time we will be taking with the cornea, all the important layers of the cornea, the corneal ulcers, how to differentiate infective and the non-infective one. So I hope all right. If the mitomycin C and conjunctival autografting both are given, then what you should choose? So maybe then they will tell you that in what aspect they are asking. I don't think that they will ask you both, I hope that you like the session. You will be definitely benefited with this, and definitely you are going to get a question or two from this in your 2022. All the best, guys. Keep on studying. Keep on sending your queries and questions related to the topic, so that whenever I am taking the sessions, I know what are the queries to address upon. And be prepared for the cornea session next time. Thank you and happy ophthalmology.